constipation and its challenges. Today, sir is going to enlighten us on gastrointestinal foreign bodies, clinical aspects, and endoscopic management. We often come across these problems in our day-to-day practice. How to treat and when to refer, it is important as an aspect of management of any disease. So let us learn in details from Dr. Dadasaheb Mendar sir. May I call upon Secretary of PDA, Dr. Ramesh Moite sir, to say a few words. Sir, please.
Good evening, friends. Dr. Ramesh Moite, PDA Secretary. I welcome you all in today's online with offline study circle lecture. Now, I also welcome today's eminent speaker, Dr. Dadasaheb Mendar sir. He is a consultant gastroenterologist and interventional endoscopist. Pune Doctor Association is one of the well-known medical association working for the cultural, sports, social, as well as medical fraternity. We have more than 1100 members, including general practitioners, specialties doctors, as well as super specialty faculties. Now, we request to all, please collect your Diwali magazine and PDI card from office time 4 to 6 p.m. Next incoming PDS attractions program is 5th December Saturday, Vaktrutva Spardha, 13th December Sunday, PDS box cricket competitions. There are 8 gents teams and 8 ladies teams. Venue, Kataria ground, 1 p.m. to 8 p.m. And 3 is 20th December Sunday, PDS Nisarga Mitra, picnic come trek, venue, Rajgarh 4. And next we'll planning our annual gathering, annual conference, DPL and Women's Day. Please give your valuable support and entries to respected coordinators. Now this unlock pandemic situation, our PTA President, Dr. Anil Lingre and his team conduct all programs successfully following all government guidelines. Thank you. Stay safe, stay healthy. I request to Dr. Arvalska Madam, please proceed.
Thank you very much, sir. Now I would like to call upon Dr. Monali Sangole to coordinate this session. He has done BHMS, CCH and CGO from Lokmanya Medical College, Chinswad. Now she is practicing as homeopath consultant and general practitioner in Omkar Clinic at Market Yard, Pune. Please, Dr. Monali.
Thank you, Sharwari Madam. Good afternoon, everybody. Thank you, PDA Study Circle team members, for giving me such a great opportunity to introduce Dr. Dadasaheb Mendar sir. He is consultant gastroenterologist, hepatologist, and interventional endoscopist. He has done his MD medicine from Government Medical College at Miraz and DNB gastroenterology from KMC Medical College, Manipal University. He has multiple national and international publications. He is practicing at NextGen Multi-Speciality Center at Decision Tower, Pune Satar Road, and NextGen GI Center at Anand Nagar, Sinhagad Road. Both centers are having consultation and procedure facility like gastroscopy, colonoscopy, sigmoidoscopy, banding, and biopsy. He is working on the panel of Bharati Vidyapeeth as assistant professor in medical gastroenterology, and also consultant at Sahyadri Hospital, Global Hospital, and Rao Hospital. This is brief introduction about Dr. Dadasaheb Mendar sir. Today, he is going to guide us on the gastrointestinal foreign bodies, its clinical aspect and endoscopic management. So may I request Dr. Dadasaheb Mendar to please guide us.
Thank you, madam. Thank you, PDA President and Secretary and all members for giving me this opportunity. In our life, till date, everyone swallowed sometime some foreign body, at least a seed of fruit, dates or something. आणि मग बऱ्याच वेळेला आपण कोणाला न सांगता चालून जातात गोष्टी आणि फॉरेन बॉडी पास होते. Why we are with this topic? Madam told me, sir, what we should choose the topic for this discussion. I told Madam many times I am seeing the foreign bodies coming from the general practitioner dealing with the rush, and patients' relatives are panic. They are worried what should be the procedure and what should happen to the baby. So everyone should know about the which foreign bodies are the emergency and which are non-emergency, which foreign body should be observed, there is no need of intervention, and which foreign body should be tackled within a short period of time. So foreign body injection is one of the commonest indication for emergency endoscopy. As I told, just many times parents are rushing with the child who just swallowed some foreign body. It is usually accidental. And mainly these cases will increase in holiday timings. Whenever there is a Diwali vacation or summer vacations, when two brother and sister, they will play, they will ask each other to just taste something and they will swallow it. So more than 80 to 90% of ingested foreign bodies will pass spontaneously because they are smooth and they are not sharp, so they will get passed. As high as 50% are asymptomatic, like seeds. लहानपणी जर आपण बघत असतो की आपल्याकडे काचेच्या गोट्या यायच्या किंवा असं एकदम गुळगुळीत मॅग्नेट यायचं आणि कितीतरी वेळेला आपण काचेची गोटी गिळायची ना, तरी कुणाला माहित असायचं, आईला माहित असायचं, वडिलांना माहित असायचं आणि ती काचेची गोटी दुसऱ्या दिवशी पास व्हायची. The real story happened a few days back. One of my friend who is practicing in the remote area, he called me, sir, one child came to my clinic and he just swallowed that goti. I told, sir, don't worry, nothing to worry. There is no need of any intervention. He was insisting me, come and please remove that foreign body. I told, sir, this is my commitment that it will get passed. Don't worry. And it passed zali. So whenever there is a smooth foreign body, there is nothing to. So that data may be from that era, from our childhood era, so that the 50% foreign bodies are asymptomatic. आई वडिलांना माहितच नसायचं असिम्प्टोमॅटिक काय, माहितच नाहीये की कोणी फॉरेन बॉडी गेली. पण now the trend is different. Facilities are available, gastroenterologist available, endoscopy available, everything is available. So whenever the child is swallowing some foreign body, we are removing within 1 or 2 hours, within 1 or 2 hours, because it is availability of the facility. So it is very common accidental ingestion. Around 1,500 to 3,000 deaths per year in US. Why there is, I'm not mentioning here India because we don't have a very good statistics regarding this. So when deaths happens, whenever there is a sharp foreign bodies, when the toxic foreign bodies, or when foreign body will get ingested into the respiratory tract, in that cases the death will happen. 80% cases are pediatric, and 80% cases, those presenting in adulthood, they are having some pathology in the esophagus, so that there is a foreign body. Means there is an infection of the normal food or normal some object due to the narrowing of the esophagus or disturbed motility in the esophagus. Less than 10% of the pediatric cases have esophageal diseases, because children are not having many pathological diseases and adults are having corrosive stricture, malignancies, motility disorder, so that whenever they are taking even a big bite of some normal food, it will get stuck because the reduced motility. Esophagus is not having that strong contraction, so it will not push that bolus into the stomach, and patient will come to us that he is not able to swallow even his saliva. He is not able to drink even a normal water. In that situation, always suspect the foreign body, and it is a simple food bolus. Just in a Diwali, I got one call from the hospital. The normal person who was eating chivda, and now he is not able to swallow the simple water. When we went with the endoscope inside the esophagus, we got one stricture, and that whatever he swallowed a bolus, it was stuck over that stricture. So he is not able to swallow his saliva as well as is not able to swallow the even water also. So we are not done anything. We just pushed that bolus with endoscope below the stricture. So now stomach will take care of the normal food. So this happens in adult patients and usually in the old age patient because they are having esophageal some pathology. So even normal food will get stuck. So in foreign body cases, only 10 to 20% will require the endoscopy. As we saw in the last slide, 50% are asymptomatic. Many patients, smooth foreign body will get passed automatically. So the only 10 to 20% cases will require the intervention and only 1% cases will require the surgery. So who are at risk? The children's, basically. They will swallow the foreign body during their day-to-day activities. Elderly patients, those are not having very good teeth, so they will swallow. It is a natural tendency. They will swallow it, and those are not having good tooths, odontologist patients, the impaired vision patients, mentally impaired patients, patient with previous GI surgery, means they are having some strictures, they are having altered anatomy. The patients are having dysmotility, like achalasia cardia, what we are hearing about, or many motility disorders. Their esophagus is not contracting well. So whenever we are eating, the upper part is pushing the food and lower part is open. So this should happen. If this is not happening, this patient will feel the dysphagia. And in that patients, the even normal food will obstruct the esophagus. Because suppose this portion is not getting open and this is pushing, then it will get impacted. Both portions are open. Again, there is an impaction. So the esophageal motility also cause the foreign body impaction. Patients having esophageal strictures and stenosis and prisoners, they will eat, swallow it purposefully to get a medical advantage. What are the common foreign bodies in the children's? Coins, bones, buttons, toys, small toys, pins, hair clips, marbles, seeds, screws, and nails. In adults, as I told, bolus, usually food bolus in adults. Then needles, safety pins, and pills. Usually, many times patients will come within the last 2 days. I am getting severe chest pain with a dysphagia. These patients are having some stricture or some motility disorder. They are bedridden, they are mentally retarded, or they are suffering from some cerebrovascular accident. They are taking their pills in a lying down position, or they are not taking adequate water. In that situation, this pill will get stuck in the mid esophagus and it will cause the ulcer. And now that patient will complain pain with dysphagia. So this is a common foreign bodies in the adults. So this is a picture of what foreign bodies we can see in the patients. So these large foreign bodies usually we will get in the psychiatric patients, not in the normal patients. But these coins will get into the children's. And if you'll see, there is a one picture. This is a dental dentature. Usually it happens during the chewing. These patients will swallow it, and this is very dangerous foreign body because it is having sharp end. It will get stuck into the wall of the esophagus when we will remove with the endoscope, and it will perforate or it will tear the esophagus. So what is the presentation? The presentation is the pain, dysphagia, complete dysphagia or partial dysphagia, drooling of saliva due to the obstruction. We are secreting 1.5 liter of saliva in a day, and we are swallowing it unknowingly. So you just imagine around more than 60 ml saliva per hour we are secreting. And if our esophagus is blocked for 2 hours, 3 hours, 4 hours, then multiply by the 60 ml. So that much of the saliva will get collected and patient will continuously spit it out. So drooling of the saliva, regurgitation, coughing, airway obstruction, hematemesis, fever, and infections like mediastinitis, peritonitis, and if foreign body will go into the small intestine, it will cause the intestinal obstruction. So last 3-4 are the complications like hematemesis, fever, mediastinal infection, peritonitis, and intestinal obstruction. These are the complications if we will not treat the foreign body within a certain time and in the right way. So how we will get the idea about the foreign body, how we should diagnose the foreign body, the best way is the history. If we'll ask the patient, they will give us a history. Usually in the children's, if we'll take them into the confidence and we will ask them what happened, they will tell us that they swallowed something during the playing, and due to the fear of parents, they will not tell us that they swallowed a toy or they swallowed a battery or something else. So history is very important. Then next is a X-ray. Always take a X-ray in a two views, that PA view and lateral view. So we'll get the idea whether foreign body is in the esophagus or foreign body is in the trachea. Usually if the foreign body is in the trachea, patient will complain of stridor, coughing and breathlessness. If it is in the esophagus, patient will complain of dysphagia, drooling of the saliva, difficulty in swallowing, and regurgitation of the food and water. And we can do the barium swallow also. The best investigation is a gastroscopy. So we can see the directly alimentary tract, what is happening there, why which foreign body is there, what is the shape, what is the other pathologies in the alimentary tract. And if we are not able to diagnose, or if patient is not stable, or if we are suspecting there is impacted into the wall, sometimes this happens. Suppose a broken glass, it will go through and through the esophageal wall, and it will get impacted into the either esophageal wall or it will go outside the esophageal wall. And our endoscopy report will be normal. Patient is running fever and odynophagia, is getting pain during the swallowing. In that situation, we should keep our thought process continue, and we have to proceed for the CT scan. Many times our X-ray will not pick up the foreign body, because foreign body is not always radiolucent. Suppose the seed is not a radiolucent. Suppose food bolus is not a radiolucent. So we will miss the foreign body. If patient is having persistent symptoms, we have to go for the advanced investigations like gastroscopy and SOS CT scan. So normal chest X-ray, it doesn't mean that there is a no foreign body. If strong history is there, strong signs and symptoms is there, we have to proceed for the further investigation. So where foreign body commonly get stuck is a narrowed part of the GI tract, that is upper esophageal sphincter, where there is a first narrowing, then aortic arch, where aorta is crossing the esophagus, left main bronchus, just below the aortic arch, and gastroesophageal sphincter. Means there are two sphincter, upper and lower sphincter. The sphincter is there, so narrowing is there, and where two structure are passing just behind the, just in front of the esophagus. These are the narrowed part, and usually foreign body will get stuck. So just in a few minutes back, I told the usually pill will get stuck into the mid esophagus. So where at the level of aortic arch or left main bronchus, and it will cause the ulcer or the pathological narrowing sites. If the foreign body will go into the stomach, then it will get stuck into the pylorus or T1, where there is a angling, there is a corner and ileocecal junction. Again, there is a wall, IC wall, and the rectum. Here is again sphincter. So wherever is a sphincter, foreign body will get stuck there. So what are the complications? Like a subcutaneous emphysema, means if there is a perforation in the pharynx or oropharynx, the air will get collected into the below the our skin, and we will get the crepitations. If we will press it, we will get the crepitation. We are calling it as a subcutaneous emphysema, or sometimes mediastinal infection or mediastinitis and air in the mediastinum. Patient will develop the pneumothorax due to the perforation of the esophagus. Just side to the esophagus, there is a pleura, and it will pierce the pleura, and patient will develop the pneumothorax. Then pleural effusion secondary to the infection. Then perforation, bleeding, obstruction, and intoxication. Intoxications is not very common because it happens only in the batteries. It contains mercury, zinc, and lot of chemicals, but the quantity is very less. The quantity required is a little bit high as compared to the content in the batteries, but it is still considered that battery content can cause the intoxication. Or basically intoxications happens mainly in the cocaine foreign bodies. Means whenever there is a foreign travelers, they are traveling, they will swallow the cocaine packets. They will keep the cocaine packets in the rectum and they will travel. So sometimes if that cocaine packets will get ruptured, they will get the intoxication. So what is the treatment? It is best gold standard treatment is endoscopic removal because this is a non-invasive. And the second is a surgery. It is required very rarely nowadays due to the advance in the endoscopy. Surgery is required only in 1 to 2% of the cases. And third is a observation. When your foreign body is non-toxic, it is a small size, it is a smooth, it will pass. So the observation is the one of the modality. So endoscopic treatment, what are the indications for the urgent endoscopy? On the patient's clinical condition, if patient is having complete obstruction of the esophagus or obstruction of the intestine, we have to intervene very fastly. What are the symptoms? Where is a foreign body located? If foreign body is in the esophagus, we have to intervene very fast because esophageal wall is very thin and stomach wall is quite tough. So if the foreign body is in the stomach, there is no need to worry. But if foreign body is in the esophagus, we have to intervene fast. So localization is important. Shape. Suppose sharp foreign body is there, we have to intervene immediately. Then composition. As I told, for batteries, we have to intervene fastly. Then foreign body endoscopic retrieval needs well experienced endoscopist, and it is always done under general anesthesia, not in the daycare. Even whatever may be, it is adult, it is pediatrics, whatever may be the age group, we have to go with the general anesthesia only. Because if we will come into our pharynx, there are two openings. One is the trachea, other is the esophagus. They are side by side. If we are removing some coins and it will get slipped into the pharynx, it will directly go into the trachea. So we have to give the general anesthesia, intubate the patient, secure the airway, and then only go for the foreign body removal. So even I am very confident that I can remove this coin very easily. I am not removing it at my center. I am always asking patient to go to the hospital, get admitted, call the anesthetist. Even for adult patients also, the same protocol is there. Always protect the airway and then only remove the foreign body. So when to remove the foreign body? Just we saw what is the content, shape, and all those things. Suppose coin, magnets, sharp foreign body, and food infection, symptomatic patients, foreign body is in the esophagus, we have to remove within 2 hours. If asymptomatic patient, we can wait up to 24 hours. If batteries, whether the patient is symptomatic or asymptomatic, we have to remove immediately within 2 hours. For the long foreign body, we can wait up to 24 hours. Means this is a time duration when we have to remove. Means before 24 hours. You can remove within 1 hour also, but not more than 24 hours. For the stomach, again, just I told, this is a weak part, esophagus is a weak. So we are removing all foreign body immediately. But if we will go in the stomach, our duration is increasing. Coins, magnets, sharp foreign body, and food, we will remove within 1 day. You can wait up to 1 day. For the batteries, again, remove immediately. If patient is symptomatic, asymptomatic patient, you can wait. And for long foreign body also, you can wait up to 1 day. So these are the different types of the instruments used during the endoscopy to remove the foreign body. This is an over tube. Means we will pass this tube in the esophagus. We'll pass our endoscope through this tube and we'll remove the sharp foreign body. Because this tube will protect the esophagus. So suppose I am holding this blade and I am pulling my endoscope back. Now this blade will cut a mucosa up to the pharynx. So it is not easy to remove the sharp foreign body. It is very risky and difficult task. In that situation, we have to use some type of protection. This is a hood. This is fit on the endoscope stick. And when I will pull this forceps, this foreign body will go inside this protective cap. And then I can pull my endoscope back. So these are different types of the instruments. What we are using, these are the forceps and baskets and all those things. So this is a whatever pictures I shown. These are the names for these forceps, like alligator forceps and snares, then magnets and suctions. So what about the foreign bodies in the stomach? Only 10% will require the foreign body removal, because if the foreign body's size, size is very important. Remember, if the diameter is more than 2 millimeter and patient is a child, we have to remove the foreign body. It will not pass. And if diameter is more than 2.5 millimeter and patient is adult, we have to remove the foreign body. Below 2.5 and below 2, we can leave the foreign body. It should not be sharp. If the foreign body is smooth, less than 2 millimeter, wait and watch. Foreign body will pass in children. For adults, diameter is 2.5 and foreign body should not be sharp. So only 1% of object that reaches will require the surgical removal, and surgery is required very rarely. 90% of the foreign body will pass within 7 days. If the foreign body is less than what diameter I told. So suppose if foreign body is passed beyond the stomach and now it is beyond our approach by the endoscope, then once the foreign body is past the duodenum, 85% foreign bodies will pass within 72 hours. We have to monitor with abdomen X-ray every 3rd or 4th day. There is no need to X-ray every day. If foreign body is not moving, that foreign body is at one side for more than a week, we have to remove it surgically. When there is obstruction, perforation, bleeding, or if foreign body is long. Again, remember which foreign body we have to consider for the removal is a sharp foreign bodies, button batteries or any type of batteries, then the foreign body more than 2 millimeter size, and the long foreign body is more than the 6 centimeter size. This foreign body has to be removed. They will not pass. They will obstruct the intestine. So what is the most dangerous foreign body? Is a button battery. It is very common in the children's because nowadays there are many electronic toys. So button batteries are available in the different size from 6 millimeter to 2.3 millimeter size. And as I told, if it is more than 2 centimeter size diameter, we have to remove that batteries. Usually it is used in different electronic atoms, and it contains mercury oxide, manganese, and zinc. So these are the toxic atoms contained in the batteries. So they will cause an ulcer. Why button batteries are very dangerous? Because the chemical will cause the ulcer. Second thing, when there is a mucosa comes near to each other, so one mucosa is here, battery is here, and other mucosa is here. So current will pass from one mucosa to other mucosa, and it will create a electrical injury also. So, and systemic absorption of the content in the battery. So perforation rate with the battery is very high. So we have to remove the battery as early as possible. If coin is there, we can wait for it. So what is the approach? They mention here more than 15 millimeter or 1.5 centimeter as a cutoff. But as per the international guideline for the children's, we have to remove the foreign body if diameter is less than 2, if diameter is more than 2 centimeter. So suspected or documented battery injection, take a chest, take a X-ray, battery in the esophagus, urgent removal. Battery in the stomach, small size battery, observe. If the large size battery more than 15 millimeter size, battery in the stomach, remove with the endoscope. Battery beyond the stomach, observe. If it is beyond the reach of our endoscope. Battery beyond the pylorus, there is no need of endoscopy. There is no option. We have to wait and watch. Otherwise, we have to post the patient for the surgery. Indication for the surgical removal: if patient is having persistent vomiting, progressive abdominal distension, means if we are suspecting the obstruction or perforation, then patient is having GI bleed, and if foreign body is not moving more than 2 weeks, then we have to consider the surgery. So these are the foreign bodies we just recently we tackled. This was the old man who was from the Hyderabad, staying with his son in Dairi. On birthday party, he was eating the chicken biryani and he swallowed the bone. He not given history at all. He came to my clinic complaining that there is a pain and unable to swallow anything. So we are suspecting some malignancy because he was old age, 72 years old person. And when we did the endoscopic, we saw this is the bone impacted in the lower esophagus at the lower esophageal sphincter. See, this is a V-shaped bone. When we are trying to pull the bone, that bone is getting impacted in the esophageal wall because it was V-shaped. So one portion is like this and one portion is like this. When we are pulling this portion is hitting the wall of the esophagus. So there is very high chance of the perforation. So what we did, we pushed that bone instead of pulling into the stomach. So now stomach acid will take care of this bone. And we plan that we will wait for the 2 days. And if this bone will not get dissolved or not get digested, we'll break with some instrument and then we'll remove. So we send patient with the oral medications like PPI and liquid antacids, sucralfate to heal this ulcer. There was a big ulcer secondary to the foreign body. And this foreign body was in the stomach, what we pushed. And after 2 days, we called back patient and we did the endoscopy and that bone was digested. It was completely broken by the stomach enzymes and acid. And it was passed through the natural tract and we are not removed it. So this is a coin swallowed by the 11-year-old girl. And this is a large size coin, more than 2 centimeter size diameter. So we removed it with the endoscopic maneuver. See, this is the peanut and there is obstruction. This is a peanut. This person came Diwali Chowda again. He was eating Diwali Chowda and he telling us, I am not able to even swallow my saliva. I am not able to swallow even water. Because see, this is like a wall. It is impacted totally into that structure. And we went inside. It was at the upper esophageal sphincter, just near the upper esophageal sphincter, 2 centimeter below the tracheal opening. And it is not easy for me to hold that foreign body and remove. And I was worried about the trachea. That patient will swallow the peanut. If that peanut will go into the trachea, he will require the bronchoscopy, he will faint, he will get the dyspnea, so many things are there. So we took a small size endoscope for the what we are using for the pediatrics. And we pushed that peanut into the stomach. So it is not always to remove the foreign body from the esophagus. If it is a food bolus, you push it into the stomach. But always remember in the mind that if this foreign body is impacted there, means there is something is wrong below that foreign body. Otherwise, peanut will not get stuck into the esophagus. So there was a stricture. We pushed that foreign body, this peanut into the stomach, and this is a picture when the peanut in the fundus, and we saw there was a stricture. So we advised endoscopic dilatation, and this patient went home. So what should be the approach? If we are suspecting the foreign body, then high risk of or unknown foreign body, child is unwell, or child is having some GI abnormality, or history is not there, proper history is not there. If anything is yes, then foreign body is likely to be radiopaque, go for the X-ray. If it is no, then discharge the patient. If on X-ray, foreign body is not seen, child is well, you can discharge. Foreign body is in the stomach, low risk foreign body, means seed, non-sharp foreign body, small size foreign body, you can discharge the patient. If high risk foreign body like sharp atoms, batteries, we have to remove it. All foreign body in the esophagus, we have to remove. Only low risk foreign bodies like seeds or smooth foreign body, we can discharge the patient. Thank you. So we'll go for the question and answer. Please, if any queries is there, kindly post in the chat box. नो. आणि आपल्याकडे एक थोडीशी एक वेगळी हे असते की फॉरेन बॉडी गिळल्यानंतर आधी आई वडील त्याला खायला देतात. त्याचे दोन प्रॉब्लेम्स होतात. एक तर आपण पेशंटला अॅनेस्थेशिया देऊ शकत नाही नेक्स्ट 6 hours. सेकंड थिंग, जर स्टमक मध्ये आपला फुल फूड असेल तर फॉरेन बॉडी शोधायची कुठं? मी एंडोस्कोप घेऊन मध्ये जरी गेलो तरी मला फक्त फूडच दिसतो, फॉरेन बॉडी दिसतच नाही. हा दुसरा प्रॉब्लेम असतो. तर ह्या दोन प्रॉब्लेम मुळे मग फॉरेन बॉडी काढायचं आपल्याला डिले करावं लागतं. आता समजा बॅटरी गिळली बच्चून, आपण इमिडिएटली काढू शकतो. आता पुण्यामध्ये बॅटरी जर गिळली तर पुण्यामध्ये एंडोस्कोपी अवेलेबल असतात, सगळ्या गोष्टी असतात, हॉस्पिटल असतं. पण प्रॉब्लेम काय होतं की आता ते खायला देतात, खायला देऊन पेशंट आपल्याकडे 2 तासानं पोहोचतो. मध्ये घरी आधी केळी, दूध वगैरे सगळं काही ट्राय करून मग आपल्याकडे येतो. मग आपल्याकडे आल्यानंतर मग तिथून आपली तयारी चालू होते. मग नेक्स्ट 4-5 hours आपण थांबणार असतो पेशंटचं स्टमक एम्प्टी होण्यासाठी. मीन ऑइल दॅट बॅटरी जी आपण काढू शकत होतो ती बॅटरी स्मॉल इंटेस्टाईन मध्ये. आता प्रॉब्लेम आपल्या समोर झाला की आता पेशंटला परफोरेशन होईल का ऑब्स्ट्रक्शन. जर नॉन प्रॉब्लेमॅटिक फॉरेन बॉडी असली, क्वाईन सारखी फॉरेन बॉडी असली, स्मूथ फॉरेन बॉडी असली तर टेन्शन नाहीये. पण शार्प फॉरेन बॉडी असली, सारखी फॉरेन बॉडी असली आणि अशा सिच्युएशन मध्ये जर पॅरेंट्सने आपल्याकडे पेशंट आणला तर मग आपल्यासाठी अवघड गोष्ट होते. आता काय करायचं? बऱ्याच वेळेला आम्ही त्यावेळेला मग अंडर फ्लोरोस्कोपी घेतो पेशंटला, वरून सियामनं मग त्या जेवणामध्ये कुठेतरी फॉरेन बॉडी शोधायची. अॅनेस्थेटिस्टला सांगायचं बाबा तू अॅनेस्थेशिया दे, आता गरज आहे आपल्याला, कारण हाय रिस्क फॉरेन बॉडी आहे. आणि मग जसं आपण वरून फ्लोरोस्कोपनं शूट करून बघायचं कुठल्या एरियात आहे आणि मग तिथं वॉश करून ती फॉरेन बॉडी काढायची. असंही काही वेळेला करायला लागतं. बट दॅट इज व्हेरी बॅड ट्रॅडिशन की त्याला केळी दिली की जाते वगैरे. आणि युजली लॅक्झेटिव्हची जास्त काही गरज पडत नाही असं करतात. तुमच्याकडे नाही आहे ना क्वेश्चन?
काचेचे तुकडे बाईट करतात. How is it possible?
देयर इज नो आन्सर फॉर दॅट. काही लोक म्हणजे असे ते आपण बघतो ना, काहीतरी चाकू खातात, काही खातात. देयर इज नो एनी सायंटिफिक आन्सर. म्हणजे नाही, त्याला काहीच सायंटिफिक आन्सर आपण नाही सांगू शकत की म्हणजे इव्हन प्रॅक्टिकली इट इज इम्पॉसिबल. मे बी. हो हो हो, अख्खीची अख्खी तलवार खातात. कुठलं? नाही नाही नाही, पेपर्स वगैरे काय प्रॉब्लेम, पेपर्स खावले तरी काय. ठीक आहे, ओके मॅडम, थँक्यू.
Thank you very much, sir, for nice and informative lecture. Please be with us for 10 minutes. There is a small talk on digitalization. Okay. Before ending this session, I would like to request Mr. Dipen Mehta, COO of DigiShield, to talk on digitalizing medical records and its importance. Please, Mehta, sir.
Thank you, madam. Can you stop the screen sharing? Thank you, PDA. Thank you, Dr. Anil, Dr. Sharwari, madam, for introducing me. I will have you talk about the digitalizing the medical records for the doctors. As in current scenario, if we compare India with other foreign countries, so India is far away behind from digitalizing their medical records. Still, more than 80% are not into digitalization. And as if we compare to foreign countries, more than 95% of the foreign doctors are using some of the platform for digitalizing their medical records. So in India, we are facing various other challenges for the doctors to convert their prescription into digitalizing. One of the most concern is the cost. It's require huge cost to implement the digitalization in purchasing hardware, computer, laptop, server. Even doctors' traditional method is also disturbed if they convert their clinic or practice into digitalization. They are used to prescribe the medicine the way they are writing in the paper and pen and have the hard copy to the patient. So DigiShield has created one application which is very easy to use and which is very convenient for the doctors, and their traditional method is also kept as it is. through the DigiShield, doctor can just prescribe the prescription on their letterhead, click the photo, upload it. Patient will receive the soft copy as well. If suppose patient has visited for the doctor on 2nd of December and doctor wants to have the patient to follow up for after 2 days or after 3 days. And many times what happens that patient forgets to bring their paper prescription. In such cases, it's find difficult for the doctor for further prescription. So if they are using DigiShield, if patient forgets their paper prescription as well, doctor just need to search the patient's mobile number or name and can have the complete patient's medical record, patient's medical history on the go. The number of time the patient visited, the number of patient visited per day, everything has been recorded, and the doctor can view their analytical reports, each and every medical records. Patients even lab reports or radiology reports are also being uploaded in the application. So suppose if there is a family patient of the any doctors who wants to do HbA1c for every 3 months. So many of the cases, either doctor forgets the date or the other patient doesn't know that he's after 3 months he has to do a HbA1c test. So through DGC lab, even doctors can able to view that on 1st of December patient has done HbA1c. So now on 1st of March patient or on 1st of Feb patient has to do again the HbA1c test. So this will also maintain the relation with the patient and the doctor. Even we DGCL has the telemedicine platform as well inbuilt. So currently in current COVID situation, many of the doctors are doing tele or video consultation through WhatsApp call or telephonic consultation. So in this through DigiShield, it very easy for the doctor. If suppose doctor has done a video consultation through WhatsApp, what about the payment part? If doctor has sent the prescription to the patient on the WhatsApp and patient doesn't pay the consulting fee or forgets to pay the consulting fees, so it's risk for the doctor as well. So in DigiShield, suppose doctor has done a teleconsultation or a video consultation and doctor has sent the prescription and patient has not paid or consulting fees is pending from the patient side, but the patient will not able to open the prescription. It will prompt the patient then message that your so-and-so consulting fee has been pending. So please click on the link. So we have a health pay as an online payment option. So once patient will pay the online through the application and patient consulting fees will be received by the doctor. After that, the patient will able to view the prescription. Unless and until a patient doesn't pay the consulting fees, the prescription will not be viewed or opened by the patient. So which helps help doctor to maintain the records, payment records, or what the consulting fees patient has paid. So everything has been maintained in the DigiShield, and it's very easy to use. It's very handy, and it can be used through mobile. No hardware or no any other printer or hardware cost involved for the doctors. And it's available free in the Android store as well as iOS app store as well. So would recommend doctors to download it now from Android or from iOS store and start using it. If you have any questions or any queries regarding the application or any other queries regarding digitalizing their prescription, you can always contact us and you can always reach out to our website www.digishield.me. Thank you. Let us know if you have any questions.
Now I request Dr. Javalkar sir, CME in charge of PDA, to give vote of thanks.
Dr. Avaskar, madam. Thank you, Dr. Dadasaheb Mahendra sir, for giving such a nice and informative lecture on gastrointestinal foreign bodies, clinical aspect, and endoscopic management in a very simple and lucid language. Really, sir, the lecture given by you will be very useful to all the GPs into the day-to-day practice. Also, the slides shown on the screen was very good and informative. Once again, sir, with warm regards and with best wishes, thank you for giving a valuable time for conducting this today's lecture to all our Pune Doctors Association members. Also, thanks to Dr. Monali Sangoi madam for coordinating this today's lecture. Also, thanks to Mr. Mehta of DigiShield for his valuable talk. Also, thanks to all the participating members for attending this online and offline lecture in a large number. Now I request our today's coordinator, Dr. Sangoi madam, and Dr. Kalpana Jadhav madam to felicitate our today's speaker, Dr. Dadasaheb Maynard sir. Dr. Avoskar madam also, that is circle interest, to join the felicitation.